So good evening, everyone. I will be speaking on neonatal COVID, neonatal multi-inflammatory syndrome, and oxygen devices. So the incidence of COVID in pregnant women is the same as that of the general population, but the severity of the disease is more in pregnant women and is associated with various pregnancy-related complications. So there is a higher risk of stillbirth, preterm births, and intrauterine growth retardation. The modes of transmission to a neonate could be in three potential ways. Transplacental passage from mother to fetus, which is relatively rare. Direct exposure to maternal blood or secretions during delivery, which is more likely. And through aerosol or direct contact from an infected mother or caregiver, most likely method of transmission. Now we know that most of the neonates remain asymptomatic or may develop only mild symptoms, as we can see in this figure here. So this figure tells us that majority of the neonates are asymptomatic or mild. Only 10 to 15 neonates may become symptomatic with fever, lethargy, rhinorrhea, cough, tachypnea, vomiting, diarrhea, or poor feeding. And even lesser than that, just 1 to 2% may develop multi-inflammatory system disease. The testing of a newborn is usually done after 24 hours of age. And if it is negative, it is only to be repeated if the newborn has any symptoms. If the patient is asymptomatic and sent home, COVID positive mother, then we follow them up for symptoms for at least up to 1 month of age, either by the visit of a healthcare worker or telephonically, they are kept in contact. Now, if we have a COVID positive mother or a suspected COVID positive mother in labor, what do we do? So there is some algorithm for this. What are the delivery room preparedness we should have? Now, the labor room should be well ventilated, should be free of draft air, and we should use exhaust fans. It can be a room which is just adjacent to the delivery area, or the resuscitation room should be physically separated from the mother's delivery area by at least a distance of 2 meters. Or a curtain can be used between the two areas to minimize the opportunities of droplet infection. One must keep a separate neonatal resuscitation kit ready in the delivery area and in the operation theatre. All the personnel who are attending to the baby for the delivery, attending over there in the labor room, should don the PPE in the proper way and follow all preventive measures for airborne, droplet, and contact infections. Mothers should wear a 3-layered surgical mask. There should be minimum number of people in the resuscitation room or the delivery room. Just one person is required in case of low-risk cases, and maybe 2 people will be present for high-risk cases where one is expecting a resuscitation or anticipating a high-risk delivery. And such people should wear a full set of PPE, including an N95 mask with a face shield and goggle. Resuscitation is done as per the NRP guidelines. There is no change in that. A plexiglass or a head box can be used for suction or intubation. Now, indications for intubation do not change. They remain the same and should be done as and when required. CPAP can be used in preterm babies. So this is our delivery room preparedness. Post-delivery, we follow delayed cord clamping and provision of KMC or skin-to-skin contact in preterm low birth weight babies who deserve it. And it should be done by the mother if she is stable or by any other caretaker, but a trained caretaker, and the same person should do it every day. There should be no rotation of the caretaker. If the mother and baby are stable and they are suspects, this dyad must be isolated from the uninfected mothers and neonates and kept differently in a different place or in a COVID suspect area, what we call the transition ward, till the reports are awaited. And once the reports come, then we'll see how the algorithm goes or what could be the situations that arise. The baby's COVID RT-PCR is to be done within 24 hours of birth, maximum 48 hours of birth, whereas the mother's is already sent in the antenatal period or intranatal period when she comes to the hospital. So what are the situations? We could have an asymptomatic child who is RT-PCR positive. So this is a neonate whose RT-PCR has come positive after 24 hours of birth, but he is totally asymptomatic. For such a baby, one should provide routine care. If the mother is also stable, then rooming in should be done with the mother. One must initiate and encourage breastfeeding exclusively. Mother should perform all hand hygiene and respiratory hygiene precautions, wear a mask when she is handling the baby and after handling the baby. And if they both are stable, early discharge should be planned. One must ensure that the vaccinations are completed before the discharge, and one has to keep a follow-up of at least 2 to 6 weeks post-discharge, which could be even via a telephonic or a WhatsApp message. If the neonate has any associated comorbidity, he should be evaluated and admitted in a specific COVID NICU. If the baby is asymptomatic and RT-PCR negative, we follow routine care, rooming in with the mother, encouraging breastfeeding, discharge as per normal criteria, complete all the birth vaccines, and keep a routine follow-up with them. Again, if there is any comorbidity in the newborn, we must admit for evaluation in a non-COVID NICU. So this is the algorithm we follow for an asymptomatic child. If the baby is symptomatic, comes RT-PCR positive, then what we should do? We should admit this baby in a dedicated NICU for COVID newborns, preferably with a negative pressure. Now, if negative pressure is not available, it can be created by installing 2 to 4 exhaust fans which drive out the air out of the room. And also the NICU should not be a part of a central air conditioning of the hospital. All appropriate care should be provided as per the standard guidelines. The staff have to wear appropriate PPE when they are nursing the baby or looking after the baby, doctors and nurses. CPAP is preferred over heated, humidified, high-flow nasal cannula oxygenation. Preferable to use closed ET suctioning method. Bacterial and viral filters can be used if they are available. And after the baby is stable and ready for discharge, all the vaccinations should be completed before the discharge of the baby. If the baby is symptomatic and RT-PCR negative, admit in a non-COVID NICU, provide all the NICU care as per standard guidelines. One has to investigate this child because he's symptomatic. He may be having any other illness, and therefore investigations and treatments are to be done. After the treatment, baby is stable, discharge is as per the normal criteria. All the birth vaccines are to be completed before discharge, and baby is called for routine follow-up. Now, one must remember, as I said in the beginning, if the RT-PCR results are awaited, because the baby's RT-PCR is sent after 24 hours, and even the mother is a suspect, both should be kept in a suspect or a transition ward. And most of the hospitals are following this criteria of having a transition ward for the newborn, for the antenatal mother separately first, then for the postnatal mother and the baby till their results are known, and then they are designated to a normal PNC ward or an NICU or a rooming in separately. Now, what to do when a neonate is born to a COVID positive mother? We test at 24 hours. If he is negative, we leave it at that and repeat it only if he is symptomatic. So if it's an asymptomatic newborn born to a COVID positive mother, mother is well, as I said earlier, rooming is to be done with the mother. It may not be possible in every hospital, then there is a rooming in facility in the ward. So separate PNC ward for them. Breastfeeding is encouraged. Mother has to wear a proper mask and follow respiratory and hand hygiene. If the mother is sick, then the baby is taken care of by a trained relative, and express breast milk can be given to the baby. Now, this has to be collected and transported with proper hygiene methods to prevent contamination, and it can be given to the baby without pasteurization. If there is no relative available or caretaker available, then this baby is admitted in an isolation ward and cared for by the nurse and doctors. Sick and preterm babies should be admitted to special neonatal or intensive care unit, and they can be given express breast orogastric tube, or if they are well, to take with a vati and spoon after they have been treated. Symptomatic COVID positive neonate, mandatory to give oxygen by whatever method is available to us, by a hood, non-invasive ventilation, high frequency nasal cannula, depending upon the respiratory requirements, or invasive ventilation as per the severity of the illness. Maintenance fluids are given, including dextrose and the electrolytes, whatever are required. If the baby is kept nil by mouth for more than 72 hours, then TPN should be initiated. Routine antivirals are not recommended. Antibiotics are added only if there are secondary bacterial infection signs. Adjuvant therapy such as steroid or IVIG, they are not recommended. There are no specific guidelines as yet for use in the neonates. One must rule out sepsis and other conditions which could mimic a COVID-like illness. If the baby is asymptomatic for 3 days, active and feeding well, he can be discharged. And one must remember that neonates may be silent carriers of the virus in the airway epithelia with prolonged asymptomatic shedding of the virus. So we are not really, actually, what do we say, safe from even newborns. One has to be very, very careful. Now, coming to multi-system inflammatory disease in the neonate, in a symptomatic neonate, the presentation is anytime between birth to 4 weeks of age. It may be variable, non-specific symptoms, just as temperature instability, rhinitis, GI symptoms like vomiting, loose motions, poor feeding, lethargy, rash, or petechiae. This baby could also have tachycardia, signs of shock, apnea, or seizures, and symptoms resembling PPHN, HLH, or DIC. Sometimes there are Kawasaki disease like mucocutaneous symptoms. Lab parameters may show leukocytosis, thrombocytopenia, anemia, elevated lactate, raised CRP, lymphopenia, low albumin, elevated D-dimer, and ferritin, just as we discussed in the preceding slides. One must do a 2D echo by 24 to 48 hours to look for LV dysfunction in these children and coronary artery dilatation and abnormalities, and also do the cardiac enzymes as we discussed earlier to rule out cardiac involvement. Now, this is a neonate typical presentation at 3 weeks with Kawasaki disease phenotype. Unfortunately, he went into HLH and DIC and succumbed. So we can see the strawberry tongue, the edema of the dorsum of the feet, also of the hands he had, and this rash which he had on the soles and palms of his hands. So this is the KD phenotype in a neonate with MISC. So as I said, rule out sepsis and other conditions, give respiratory support, oxygen first, very judicious use of fluid resuscitation, slow boluses, and 5 cc to 10 cc per kg at a time with clinical monitoring for any deterioration. Then you stop it because it could be cardiogenic shock. There should be a thermoneutral environment for nursing the babies, and one should have a low threshold for using inotropes in case of shock. IVIG 2 gram per kg over 12 to 24 hours can be given, 1 dose, and we have already seen that it is indicated in KD phenotype. MPS can be given 1 to 2 milligram per kg per day for 3 to 5 days. So this forms the mainstay of the treatment of MISC even in the neonates. Empirical broad spectrum antimicrobials can be added. If there is coronary aneurysm or dilatation with Z-score of more than 10, evidence of thrombosis, or left ventricular ejection fraction is less than 35%, then low molecular weight heparin 1 milligram per kg subcutaneous twice a day is started till the time of discharge. When the baby is asymptomatic for 3 days, active and feeding well, it can be discharged. And this baby should also be vaccinated as per schedule before the discharge. Now, coming to oxygen therapy, this devastating pandemic has taught us many, many lessons. And one of them is the importance of oxygen therapy as a life-saving drug. Especially in the second wave, the number of infected population, mainly the adults, escalated, unprecedentedly increasing the demand for oxygen resources for treating the hypoxic patients. And therefore, it is time now that we should learn to use oxygen judiciously and with appropriate devices for deserving patients. The aim of oxygen therapy is to reduce the work of breathing and achieving SpO2 of 90 to 94 with minimum FiO2 with an appropriate device. So we look at some of the devices. Now, a face mask is the most commonly used. But as we can see that the limitations are of air mixing because of the external ports, the open ports that it has to the side ports. Also, very high flow rate of 5 to 10 liter per minute is required, and the FiO2 delivered is just 40 to 60%. The advantage is that nebulization can be given when the chamber is attached to it. Coming to nasal prongs, these are easy to administer, they are well tolerated. It provides low level of oxygen supplementation. So the FiO2 is just about 25 to 45%. And in a child, a flow rate of 5 liters, less than 5 liters per minute is most often used because of the increased nasal irritation with higher flow rates. A partial rebreathing mask, it has an unreliable delivery, but it is easily available, gives an FiO2 of 40 to 70%, and it also requires high oxygen flow rates of 6 to 15 liters per minute. Coming to a non-rebreathing mask, yeah. The thing is that it gives one of the highest FiO2s, about 80 to 85% with no air mixing, as there are one-way valves placed between the mask and the reservoir, and the other is at the exhalation ports. Now the second exhalation port has a small valve, has a outlet with no valve. And this works as a safeguard to allow some room of air to enter into the mask if in case there is disconnection from the oxygen source. And the limitation is that it has 8 to 5 liters of oxygen demand. So 10 to 15 liters of oxygen is required. And this is one of the limitations. So when we are talking of scarcity of oxygen, we need to think about non-rebreathing mask, though it is one of the best and gives very high FiO2s. Oxygen hood can be used only for neonates and infants, cannot be used for children more than 10 kg, and there is a lot of CO2 retention. It also requires a very high flow rate of 8 to 15, and the FiO2 delivered is 70 to 90%. This is most commonly used by us for neonates in most of our hospitals. Now, Venturi Mask. This is the Venturi Mask, which provides a preset FiO2 through a mask and a reservoir system. So here we can set the FiO2 that we want. The adapter is useful for this. The oxygen flow rate required is about 5 to 10 liters per minute, and it gives an FiO2 of 30 to 50%. Coming to CPAP, BiPAP, and HFNC, which are the non-invasive positive pressure ventilation methods, the prerequisites are that the patient should have an independent respiratory drive, intact airway reflexes, a good sensorium, should be cooperative and alert. And what is used as CPAP, BiPAP, and HFNC. So a CPAP is an underwater bubble CPAP which gives a continuous flow in at one pressure only. It delivers heated humidified air to the patient through a secured low resistance nasal prong cannula. Compared to that, a BiPAP is slightly superior because it provides separate pressures during inspiration as well as during expiration. So the positive airway pressure can be adjusted for the exhalation and additional positive pressure for inspiration. So it works like a PEEP during for improving the oxygenation and also improves the alveolar ventilation in low compliance and obstructive lung disease. Advantages are it can avoid intubation, complications, and cost. And it reduces the venous return to the heart, which may be actually a disadvantage in a setting of hypotension. Plus, it decreases the mortality in properly selected patients. And the disadvantages are, as you can see, this contraption has to be very tightly adjusted on the forehead and the face, and the mask is very tightly applied. So it causes a lot of patient discomfort and can cause facial skin necrosis. Most patients do not tolerate it, are not cooperative for it. The other disadvantage is it reduces a venous return to the heart, which may be an advantage in a volume overload. Now coming to HFNC, The oxygen delivered is at a flow rate of 4 to 16 liters per minute, and up to 60 liters per minute can be given. The FiO2 can be adjusted by provision of gas flow through oxygen blenders. Another benefit is the CO2 washout. So it helps in the CO2 washout from the nasopharynx and decreases the CO2 and the dead space. Disadvantages are there is the delivered distending pressure is variable. It is an aerosol generating procedure. Higher pressures can be delivered, but again, very tight nasal prongs are to be fitted and the mouth has to be kept closed. There's a risk of over distension if the prongs are too tight. Plus, its cost. It's quite a costly equipment, and therefore we are not really, not many hospitals have HFNC.